Now let's talk about macrocytic anemias. Well, the macrocytic anemias, when you have the MCV greater than 100, it's now macrocytes, the big cells. So macrocytic anemias. The first thing we have is the megaloblastic anemia. Megaloblastic anemia, you have impaired DNA synthesis. And why do you have impaired DNA synthesis? Due to either the folate deficiency, vitamin B12 deficiency, okay, which leads to maturation of nucleus. You have maturation of the nucleus of precursor cells in the bone marrow. Delayed relative. So maturation of nucleus is delayed relative to the maturation of cytoplasm, because the nucleus needs the vitamin B12, the folate, for it to be completely mature. It needs them. So when you are deficient in either of them, it causes delayed maturation relative to cytoplasm. What are the causes? B12 deficiency, folate deficiency, medications. Hydroxyurea cause that, phenotoxin cause that, methotrexate and sulfa drugs. The findings in megaloblast are RBC macrocytosis, big RBCs, hypersegmented neutrophils greater than 6 lobes of neutrophils, glossitis. Okay. RBC macrocytosis, it's also known as macrovalocytosis. Macrovalocytosis. Okay. Large, bizarre shape. Also, you will have a large, bizarre shaped platelets. Okay. So immature. So when you have this maturation defective, that means you have the immature cells. Immature are larger cells. They have enlarged RBC precursor cells like macrocytic RBCs. So these big RBCs now, because they're immature, they just come out. They are more prone to hemolysis because they're big. In small arteries, they can go there in sinusides and spleen. So they will go into hemolysis. When they go into hemolysis, you will have increase in bilirubin levels and increase in LDH levels. That bilirubin will cause increase, that will cause jaundice, increase in unconjugated bilirubin, so it will cause jaundice. So that's through the RBCs. Other things are all the cell lines are enlarged. So we just talked about the RBCs, but the granulocytes also enlarged. So you have neutrophils, which are greater than 6 lobes. You have also seen in the platelets that we talked about, but also one more thing: rapidly dividing cells, they need the vitamin B12 and folate because they're rapidly dividing, right? So these are the intestinal epithelial cells. So megaloblastic change, like big cells, megaloblastic change is also seen in the intestinal epithelial cells as they are rapidly dividing. Okay, now let's look at the tiny details of folate deficiency and vitamin B12 deficiencies. So folate deficiency, first of all, you got to know that the body stores for folate are minimal, and body stores for vitamin B12 are heavy, means a lot. So if you have a folate, minimally levels of folate stored in the body, guess what? If you don't take a lot of folate, you are going to go into folate deficiency. Well, on the other hand, you have heavy storage. So it's going to have some time in order for you to have a vitamin B12 deficiency relative to of the folate deficiency. I hope the point is clear. So let's talk about the causes of folate deficiency. You have malnutrition. Example, in chronic alcohol overuse. Alcoholics, they decrease the dietary intake. They're like, I need alcohol, man. Forget food. I need alcohol. That's what alcoholics do. So they forget to take diet. With the diet, they don't take diet, they only take alcohol. That impairs, and that's the dietary intake, and also the alcohol impairs folate absorption. Okay. So if you have a chronic alcoholic patient, they can develop anemia within weeks. Okay. After consuming lots and lots of alcohol. And this is the most common cause. Okay. And the third thing the alcoholics would have, chronic alcohol leads to some inflammation. What inflammation? Pancreatitis. And pancreatitis leads to both the folate and vitamin B12 deficiency. And the second thing is malabsorption. And the drugs being methotrexate, trimethoprim, phenytoin. Increase in requirement, for example, in hemolytic anemias, you increase the requirement in pregnancy. That's why you give folate in pregnancy. Before even you start pregnancy, actually. Okay, so let's talk about the labs or findings. What do we have? We have increase in homocysteine levels, normal methylmalonic acid levels, no neurological symptoms, versus vitamin B12, which has neurological symptoms. Okay. Again, what's the differentiating feature between these two? In both of them, you have increased in homocysteine levels, but let me change the color. But in folate, you have normal methylmalonic acid, and you have no neurological symptoms. And in B12, you have increase in methylmalonic acid levels and with neurological symptoms. So let's talk about B12 deficiency. B12, also known as cobalamin. Cobalamin deficient, for example, the causes are pernicious anemia. You have malabsorption, for example, in Crohn's disease. Crohn's disease malabsorption meaning, remember the Crohn's disease. Most common location is terminal ileum. Where the B12 gets absorbed from? Terminal ileum. So if you have a Crohn's disease, most common location is terminal ileum. You're knocking out terminal ileum. You cannot absorb vitamin B12. Pernicious anemia, think about it. Intrinsic factor deficiency. Where was IF coming from? IF was coming from parietal cells. So you have autoimmune destruction of those parietal cells. You cannot release IF, intrinsic factor. It's called pernicious anemia. Pancreatic insufficiency. You needed the pancreatic proteases to come down and release that R binder that was attached with the vitamin B12. Remember your GI, that you needed the pancreatic enzyme proteases to relieve that R that was attached with the vitamin B12. And once you relieve this one, the vitamin B12 will attach with the IF. So if you have pancreatic insufficiency, you cannot relieve this R. When you cannot relieve the R, guess what? You cannot bind it to IF. Guess what? You cannot absorb in terminal ileum, leading to vitamin B12 deficiency. Other things, and very importantly, you have vegan diet. I am a vegan. I'm just saying. Well, I am not. Okay, I'm just saying vegan diet. So they must take some supplementation of vitamin B12 because you're not getting it from your vegan diet. I only drink almond milk because I'm vegan. Well, please take your vitamin B12s. Okay. Gastrectomy. Gastrectomy meaning you have no acid, right? When you have no acid, that decreases. Acid is coming from parietal cells, and basically no acid, no parietal cells, no IF. No IF leads to vitamin B12 deficiencies. And then you have the Diphyllobothrium latum fish tapeworm. That also causes that. Some other things that they haven't mentioned are very common chronic antacids or PPI use, proton pump inhibitors. Again, same thing. Inhibit the parietal cell, no IF, no vitamin B12. And metformin. Metformin. That also is associated with vitamin B12 deficiency. Okay, now let's look at the neurological symptoms. What are the neurological symptoms we can have in vitamin B12 deficiency? Well, it's going to be reversible dementia, subacute combined degeneration of the spinal cord due to the involvement of B12 in fatty acid pathway and myelin synthesis. So because we don't have all this, we are going to go into subacute combined degeneration of the spinal cord, which will give you spinocerebellar tract defects, lateral corticospinal tract defects, and dorsal column dysfunction or defects. So all of that give you like poor proprioception, ataxia, leading to recurrent falls, and decrease in vibration proprioception is the early sign. Decrease in proprioception and vibration sense is the earlier sign. Let's talk about folate. Very important now. This is very important also. Folate supplementation. You have a vitamin B12 deficiency and you're like, oh wow, let's just give them folate. Guess what? You're worsening the neurological symptoms. You have multivitamin and you have folate in there. Somebody has vitamin B12 deficiency and you give multivitamin which also has folate. Well, you're worsening the neurological symptoms. Okay, they're very important. Folate supplementation in vitamin B12 deficiency can correct the anemia, but worsens neurological symptoms. Recurrent falls. You don't know where they're gonna fall. Okay, so very bad. But let's talk about historically diagnosed with Schilling test. That a test that determines if the cause is dietary insufficiency versus malabsorption. Anemia secondary to insufficiency intake may take several years. Again, look, we said it's heavy stores. So secondary to insufficient intakes may take several years to develop due to liver's ability to store vitamin B12 versus folate deficiency, which just takes weeks to months. So it takes years for the deficiency to work if you are taking insufficient diet. Vegans takes years to develop. I'm cool with vegan diet. That's, and after years, man, I should have taken vitamin B12. But moving on to orotic aciduria. Now here, one more thing, guys. Here, one last thing. When you treat the deficiency, you will have an increase in retics, right? So there's a graph. The graph is, if you were to give treatment 1 week, 2 week, 3 week, 4 week, 5 week, and so on. So these are the number of weeks: 1, 2, 3, 4, 5. Erythrocyte levels, you will have increase in retics at the first week. So basically, yeah, something like this. And eventually, after the 1 week, it's just gonna decline. Okay. As compare that with your hemoglobin concentration, so HB levels are going to increase slowly. And these are your erythrocytes. Erythrocytes, they look at by 1 week, when you give the treatment, they will rise. You will have lots and lots of reticulocytes. So look at the graph, so much reticulocytes coming out because there was deficiency. Now finally they got the nutrition they needed, they were waiting for it, and they're like, boom, let's make these things, and they'll start making them. Okay, but eventually after 1 week it's just gonna decline over time. And on the other hand, you have the HB levels, hemoglobin levels. They are slow to rise after the treatment. Okay, so yeah, that's all for folate and vitamin B12. So let's talk about orotic aciduria. Orotic aciduria is the inability to convert orotic acid to UMP, which is a de novo pyrimidine synthesis pathway, because of defect in UMP synthase. There's an enzyme defect, which is a UMP synthase. It is an autosomal recessive disease. It presents in children as failure to thrive, developmental delay, and megaloblastic anemia refractory to folate and B12. So you have a children who has a megaloblastic anemia. You do give folate vitamin, and if nothing is working out, because you have the enzyme which is deficient, it's not the folate and B12 deficient. Okay, no hyperammonemias versus or ornithine transcarbamylase deficiency, which again also causes increase in uric acid, but with hyperammonemia. Okay, very important. So here in uric aciduria, all you got is UMP synthase deficiency, or by defect in this UMP synthase. You don't have the UMP synthase, and failure to thrive, development delay, megaloblastic anemias, which are refractory to folate, but importantly, no hyperammonemia. Versus if you were to have an ornithine transcarbamylase deficiency, this is UMP synthase defect. That is ornithine transcarbamylase deficiency. You will have in hyperammonemias. So when you don't have this enzyme, the uric acid is going to go back into the blood, goes into the urine. Treatment is, how do you treat this? Uridine monophosphate or uridine triacetate to bypass the muriate enzyme. So basically, you're giving these things, you're bypassing this enzyme, and you're making the product of that enzyme, whatever it was making. And you can go back to your biochemistry, maybe like second, third page in your book, and take a look at it. Okay, that's all.